Good evening, everyone, and welcome back. Next up on our agenda is a talk by Professor Usha Menon, who is an esteemed member of our Clinical and Public Health Fellowship Selection Committee. She's from University College London, and she's regarded as one of Britain's foremost gynecological cancer specialists. We look forward to your talk, Usha.
Good afternoon, everyone. Madan is too kind. It's a real pleasure to be here and to talk to you about my work. I'm spending half my time at THSTI as well, but the work that I will speak about is what I have been doing so far at UCL. This is my disclosure, to just set the scene, I'll define ovarian cancer because for those of you who don't work in the area, it's more than the ovary. So the cancer arises also in the tube and mainly from the tube that's what we do now. And it included primary peritoneal cancer, but at least now in 2014, WHO has changed the classification so that what is primary peritoneal is now just primary peritoneal, and those ovarians that were called primary peritoneal will now be either fallopian or ovarian. There is a variation in disease incidence, and you can see in this global graph. It's more in affluent countries, so you might think, what is the relevance to India? And this is from the Indian registries, and the line on top is in red is the UK rates, but you can see from the urban registries in India, there is now an increasing incidence of ovarian cancer. And the issue is that not only is the cancer incidence rising, but if you look at the number of deaths, you can see that there are about 239,000 new cases reported and about 151,000 deaths, so a very high case fatality ratio. And though we have made a lot of progress in many ways, this is UK stats, but it's similar across many of the Western countries. You can see that we've had about only a 19% decrease in mortality from ovarian cancer between the 70s and now. And the 5-year and the 10-year survivals are shown, and you can see there's not a huge trend to improvement. And our 10-year survival is running at 35%. So this is because mainly patients are diagnosed in very advanced disease, and as you can see, there's a lot of ascites. I mean, you open the abdomen, there's disease in the upper abdomen. The omentum is caked. And most of these patients who are diagnosed in stage 3 and 4, as you can see in the front, they have very poor 5-year survival. But there is a minority of patients who are diagnosed in stage 1 and 2, and they do well and they have better survival. So of course, the question is, could we screen and pick up these women earlier and impact on mortality? So when it comes to screening, just to say that screening is of course looking for early signs of any disease that you're screening for in apparently healthy people who do not have symptoms. And it's helpful to think about it, and this is not a pictograph that the NHS screening committee often uses, or think of it like a sieve. So the screening test, as you increase the size of the diameter of those holes in the sieve, you can either put up your sensitivity or your specificity, and it's a very nice way of thinking about it. And once people go through and you think that they're at increased risk because of a screening test, you still have to do more tests to sort out whether they really have the disease or they don't. And so it's really a whole strategy rather than a test. And our challenge in population screening, and I'm not going to talk about high-risk screening, I'm just going to talk about our work in population screening. If we target women over 50, then this is what we need to do, pick up one woman in 2,000 or in 2,500. And the journeys, really the first screening tests were described. So in early 1980s, so Bob Bast and Bob Knapp, they described CA125 and set up the RIA, the radioimmunoassay, to measure it. And at the same time, in UK, Stuart Campbell he was first in Glasgow and then came down to London to King's, and he started doing real-time pelvic ultrasound and describing the ovary in its volume and its appearance. So Ian Jacobs, who was then just a fellow, and he had gone and worked for a year with Bob Knapp and Bob Bast, and he came back and he wanted to start the first randomized controlled trial for ovarian cancer screening. So unlike us and everybody here, he had no grant, but he's like he's very enthusiastic. So he just wrote to the top 100 FT companies in UK saying that, can you give me some money? This is what I want to do. And that is how the trial started. It was very ambitious. He had a strategy, CA125 first and then ultrasound next, and he randomized 22,000, first screened 22,000 women in East London from Bart's. It was all on paper. We had little cards. I was not part of it then. And then after he did the first screen, he randomized the women, so the 22,000, so that 10,000 had 3 screens and 10,000 had were in the control. So that by the end of the 90, by 1990, he had some 48,000 CA125 results. And he had a strategy which showed that he could pick up 75% of the women, and 4 women were getting operated. So women would have to have a laparotomy if we thought that they had ovarian cancer. There's no biopsy, so we didn't have the breast biopsy option, like the breast cancer screening option of a biopsy. So women would have to have surgery, and it was 4 ops per case detected. At the same time, there was a statistic there. Steve Skates was working also with Bob Bast, and he was from MGH. He was a Bayesian statistician. He is a Bayesian statistician, and very interested in looking at trends. So he was looking at data, and he met Ian. He came to spend the summer at Bart's, and they refined the algorithm. It was clear that women who had flat levels of CA125, even if they were raised, didn't have ovarian cancer, as in this site. And women who had ovarian cancer, they had what is called a change point. And he developed a Bayesian algorithm called the risk of ovarian cancer algorithm, which basically the way it runs is, it's got this database of serial CA125s from cases and controls. We put in data from a woman, and it fits her curve between these two, and it gives us an estimate. So he developed this risk of ovarian cancer algorithm, predicted on modeling that it would have an increased sensitivity of 85%. And at this point, I joined Ian as fellow, so this was 1996. And when I joined, there were all these cards from the 22,000 where all the scans had been done, and they were just stacked. So my first job was then, data entry was my first job. So we entered all the data and then refined the ultrasound side of the algorithm. We were no longer going to use cutoff morphology. It would give us a better readout and higher specificity. And then with this new refined algorithm, which had a new way of looking at the CA125 and a new way of looking at the ultrasound, we started the next pilot. So this was a pilot randomized controlled trial. We wanted to see whether we could do this. So we were going to run this test first line, triage into low risk, they'd come back in Nanville screening. Intermediate risk, they'll have a repeat blood test, and high risk, they'll come through immediately to have a scan on a CA125. So we started recruiting. All of this, of course, without a grant. So when you don't have a grant, you're like in the basement. So this is Bart's, and we were like in the basement, no windows and all, for a research group that does not have grants. So, but by this time, what happened was the women who had been randomized and who had had their screen in the late 80s, it was 8 years, a mean of 8 years since their randomization. And what was clear is that on an intention to treat analysis, there was a survival benefit. Of course, the numbers, as you can see, are very small, 10 and 16. So it just is suggesting that there might be something there, but not really like definitive of impact. And as you do know, and I think the breast cancer kind of story is very live last few years, you have to have a proven mortality impact to kind of start population screening. So this is a point we were. So we had, the group had, Ian had started with the studies, we had a series of studies, we had all these refined algorithms, and we had a significant survival impact. So we had to either take the final plunge or just shut shop and go and do something else. So we said that we'd go ahead and do this definitive trial to create all the evidence we need to persuade the NHS and anybody else, any other government who would be willing to institute a population screening program. So the questions we had to answer were, was it acceptable? Would women comply with year-by-year screening? Would it be cost effective? The women who came through the sieve, how much anxiety would we create in them? And then after we did our series of tests, those who went to surgery, what would happen to them? What would their complications be, especially the ones who didn't have ovarian cancer? And our primary outcome was death. And of course, the whole rationale was a stage shift, so we would have to kind of show a stage shift. So at this point, there were 3 of us, but it was clear that 3 wouldn't. This is really team science in a big way, clinical trial. So we immediately needed more people. So it was a bit of the year, 6 months was just, I was either on the tube or in some bus or car just going across London, trying to get the various other people to join the team. And so Max joined from MRCCTU as a trial statistician. As I said, we needed to look at anxiety and quality of life. So Leslie Fallowfield joined as Professor of Psycho-Oncology, and if you work in the breast cancer field, you might know her. She's got massive amount of work in that area. Ali Maguire joined as a health economist from London School of Economics, and we went and asked Prof. Campbell Stewart had come down to London. He was at King's to join us as the ultrasound guru. So we then had a trial design. It was clear we would have to have 200,000 women recruited, and with 50 to 74 postmenopausal. And when we started, we thought 100,000 control arm, 100,000. We had our screening strategy, multimodal, and that's what we were going for. You know how grant review bodies are. We went for first round. They sent us back saying, if you're doing it and we're giving you the money, do both strategies. You need to do a head-to-head between both strategies. So we randomized within our study arms. 50,000 women would go the way we had planned, multimodal screening. 50,000 would have an ultrasound strategy, first-line test ultrasound. And the plan was 6 annual screens. We'll censor at 7 years post-randomization. It'll give us 80% power to look at a difference in deaths of 30% between the arms. So for the first time in the UK, the grant funding bodies came together, MRC, CRUK, together with the Department of Health, and in fact, it was not CRUK then, but, and they funded the trial. And we had, we needed 13 trial centers. That was how the budget worked out. And we were hoping that Scotland would come on board, but just because of certain logistic issues, it didn't happen. So we had Ireland and England and Wales in the trial. And so this 13 centers covered about just over 3,000 GP practices. There was really, so we had the grant and we had all of this, but really on the floor there was just 2 people. There was a manager, the project manager, and myself. So we had to really ramp up very fast from 15 to 200,000. So the first thing was getting the trial system set up. So unlike now, when you could go and buy some stuff off the shelf, there was nothing of that available then. So we had to write the tech spec and build it. And we built it with a firm that was building Lloyd's shipping databases. So they were very good at database building, and they were very keen to try and work in a different area. So it was really good fun, but we had a really nice database which did everything for us. And it was important because 200,000 women, and our promise was, if you have an abdominal test, we'll call you back in 6 weeks, we'll call you back in 2 months, and we had to keep all those timelines, not lose anybody while we went through this whole exercise. We had to have, the women would be giving us blood, and so we were going to do CA125, so immediately this research lab that we had had to become an accredited lab, and those who go through clinical accreditation know how painful that is. So we had to do that. We had a lot of samples coming in, so that had to have a biobank facility set up, logistics for the transfer samples, and then of course we were going into large-scale screening, so 50,000 ultrasounds would have to be provided every year. So that was really the biggest challenge for me, just getting the training, getting the people, finding the people. There's always a shortage of staff, as you know, in the UK, and the NHS was not appreciative of us trying to steal their staff to do our trial. So various people joined the team, and through the years they have worked on the trial with us. I want to highlight two people especially. Andy Ryan. I had really come to do a PhD with Andy Ryan. He was the scientist in the wet lab, but I did a clinical trial and then persuaded him to leave the lab. So he manages all our data. And Alex Gentry Maharaj, who's one of the senior postdocs. We had, the way the trial was funded was, you know, the center at UCL, of course, had a research grant, but all these 13 centers, they were going to be paid per woman recruited by the Department of Health. So they had like trial teams, and we had salaries to pay. So you had to hit the recruitment target because and so the target we had to hit was 120 women had to be recruited for 44 weeks in a year. And I had run a lot of time motion studies how to get this done, and we had a whole system of exactly how to do it. And plus, over the years we were recruiting, so we didn't want patient information to be different in different centers and over time, so we had a video made. And so everyone would watch the video and then have a group discussion and then consent. There were many challenges, but I have to keep to time, so I won't tell you all those stories. You can chat afterwards. But just over 4 years, we invited 1.2 million women and recruited just over 202,000. So I realized once when we got a cake from the postal department in UCL that how much post we were sending out to them, because it was like 5,000, 10,000 letters going from our department to all these people. So while the recruitment started, immediately we had to start the screening. And there were, like I said, 2 screening strategies. It was a strategy rather than a screening test. And all the data was being directly kind of fed into this trial management system. So the bloods would come, the analyzer would run it, and the analyzer would directly upload the data into the trial management system for classification. And from the sites, the women, the ultrasonographers would enter the data onto the web, onto the scan forms. For the bloods coming through, we were expecting, and we got just over 500,000 samples from these women in the course of the trial. And what we had decided was we need to automate it as much as possible. So we use this system which is like collecting the blood. You know, it puts the blood into these straws, so it sucks up the blood into 500 microliter aliquots, heat seals both ends, and then barcodes and reads the barcode and gives us an address. So, and this was for our secondary studies in the future. Follow-up was through, really it was one thing that would have been very difficult now because of all this data protection and the new GDPR. But at that point, we had consent from the women. We were able to connect to the NHS numbers and flag through cancer and death registry. We also did follow-up ourselves. So things were going really well, and I thought 2008, I mean, they started going really well. 2008, I thought, oh, things are settling and we can do some science now. Before we were running a logistics company. And then the first of the women had just finished, they were coming up to their 6-year screen over. I was just getting ready to write to them, thank you so much, and stuff like that. And then we looked at the control arm of the trial. So when we looked at the control arm of the trial, we were 5.5 years into the study. And in the control arm, the deaths were 37% of an age-matched UK population. So you remember there were 1.2 million women and 202,000 joined our trial. So really, if you had a cohort study, we could have thought that this was because of our screening. But this shows you why you need to have a randomized control trial. So you can see, if you can see at the back, everything that's due to every kind of cancer was down. And if you look at deaths due to really cardiovascular disease and respiratory disease, they were really down. And I guess these are the people who decided to take part in our study. They were signing up for a 10-year trial of screening. So of course, there were people who believed in health. They probably had much healthier behavior. They probably smoked less and did more exercise than the whole UK cohort. So of course, we were back to, we won't have the power, we don't have the events. We are in 2008, so we had to redesign and think again. So we decided various options and decided to extend screening till 2011. All women would be screened till 2011. So depending on when they were recruited, they would have 7 to 11 screens. And we had primary analysis of primary censorship December 2014. Of course, this meant we had to go back and ask for a lot of money. We were becoming very unpopular because, of course, whatever money we got, and people had to give us money because they had already committed to giving us money, and so much had been done. It was coming from some pot, so it meant that someone else was probably not getting the money. So I don't know how popular we were. But by December 2014, we had completed just over 340,000 screens in both arm median number 8, and we had complete follow-up in 99% of the women because of the flagging, and we were just over 2 million women years follow-up. So it was time for results. I'll quickly show you the ultrasound results because we had no stage shift. So we had no stage shift, and therefore we had no mortality benefit. So this COX was our primary analysis. There were a couple of other analyses. And as you can see, though there's like some trend, there's a trend towards mortality reduction on this side. This is the 0 line, and all the confidence intervals are crossing 0. So when we came to multimodal analysis, so there was high compliance. The sensitivity was as we had predicted, like back in the 90s, it was 85%. We were managing to hold on to that 4 operations per cancer detected. So that really translated into 14 women having unnecessary surgery for every 10,000 screens that we did. So when I say unnecessary, I mean they had a laparotomy or laparoscopic surgery with removal of tubes and ovaries when they had either no disease or just some benign pathology. The major complication rate in those 14 women was 3%. We had higher sensitivity with our ROCA than than if we had used a cutoff, and we had a stage shift. So we had a stage shift which is significant. The question is whether we looked at stage 1, stage 2, or low volume disease. But when we looked at our mortality, if you look at the p-value, we have a 15% reduction, which is not significant. So the COX looks at, the assumption is proportional hazards. That is, it is an average reduction, which is same throughout the years. But when we looked at it more, between 0 and 7 years, the reduction was 8%, and then between 7 and 14 years, the reduction was 23%. So there was a delayed mortality effect. But the analysis that we had chosen, and now when you start thinking about it, of course, there is some delay because it's a screening trial, it's not a treatment trial, so women have to, in the control arm, to be diagnosed with ovarian cancer and then die before we can see a benefit in the screen arm. So there will be some delay. But we had not taken that account, so important to think about your pre-trial, your stats analysis plan. We had a stats analysis plan which did not take that into account, so a p-value is not significant here either. After seeing the data, we did a single post hoc analysis which did use the weighted log rank, which takes into account a delayed effect, which showed significance. It was post hoc. As you know, it cannot be written as abstract, and we have seen the data, so that is not really considered okay in a clinical trial setting. when we looked at what was happening to the mortality rates at this point, as you can see, the control arm mortality rate was still rising. And the rates in our multimodal and ultrasound arms had sort of plateaued. And though we thought 30% mortality benefit, you can see that, you know, we were looking at a smaller mortality benefit. And in the breast cancer trials, these are the kind of benefits that mortality reductions that you see, and ours was somewhat in that ballpark. The Leslie Fallowfield's group showed that psychological morbidity was not significant. There was no long-term harms, and the multimodal arm was more favorable. A number of cost-effectiveness analysis was done. The NHS Screening Committee commissioned Sheffield to do an independent analysis, and their analysis and our own analysis suggested that, you know, if this was a true effect, it was within the national willingness to pay threshold, so it was something that the NHS might take up, of course, if there was a mortality benefit. There have also been 2 US analyses using the data. So this is where we are. So we are about now, I don't know, almost 35 years into this venture. We are all together still and have not fallen out. And we are still continuing follow-up. So the plan is that, you know, that those curves are kind of parting. And as you can imagine, what would happen is that the curves, if you stop screening, what happens is there's a time when the curves are together, the mortality curves, then they part, and then they come back together because there's no longer screening going on in the cohort. And so this is, you know, the whole mortality benefit may not have been realized, and it seems to be more in the 7 to 14 place. So that is what we are at now. We have a NIHR HTA grant. We're looking at further follow-up in this group, waiting for 230 events in the control arm. So we are expecting somewhere between Jan and June next year to censor and do our next analysis. We are a group where at different times, different people are optimistic and pessimistic about what this outcome might mean and what all our years of work might mean. In the meanwhile, from Toronto, Steve Narode has done some independent modeling. He's taken our stage shift, and then you've taken SEER, American incidence and survival rates, and he's done some million simulations, and he got a hazards ratio of 85, which is a 15% reduction. But I think, let's see what happens. So this is where we are. Still an unfinished journey. We've got lots of pieces of the jigsaw done, but we still have to find out whether that mortality benefit holds. We have this huge amount of samples, so there's a lot of work going on novel biomarkers. These samples precede the diagnosis of cancer by anything by 4, 5, 6, 7 years. There are multiple samples. Our own work is very much in longitudinal algorithms. We work with a lot of mathematicians who do some really kind of stunning work on longitudinal algorithms. There are, in addition, there's a lot of work going on by other groups, and we contribute to defining the target population better, and that would increase, of course, the performance of the algorithms. So I just want to finish by saying that, of course, I'm standing here, but it's huge team science. And first of all, I want to just acknowledge the women. 200, you know, like I said, 80, 90%, we had 80% compliance, and these women came year on year, 10, 11 years. And this is not because of the doctors or the researchers, it's because the receptionists were so nice to them, and the nurses were so nice to them, and they came every time that they continued to come, and we had to do all of that. So when we finished, I got an artist to paint a Graphian follicle, and we digitized it so that each dot was each woman, and then we posted that card to everybody with a saying thank you. I have to thank the funders, the oversights committees, the huge team that all across both the NHS and the universities who supported this. And when we finished, of course, like I said, we didn't have a mortality benefit, but what I really liked was the Lancet's acknowledgement of the widespread collaboration that was shown by this trial, and how what they wrote was if you ask the right question at the right time, you can get lots of people to work together. And I think that fits in very well with the team science call. I'm sure you'll get lots of right people working together to do some great science. Thank you.
Thank you, Professor Menon. Extraordinary piece of work. Yes, Ashok.
Usha, I mean, UKCTOCS was a fantastic achievement, which I think is really widely recognized. My question is really concerning the change in modality, since, of course, this massive trial was initiated some 10, 15 years ago. And I'm sure you're well aware of advances, for example, Tomasetti and Vogelstein with
Yes.
the cancer-seq methodology.
I did have a slide.
Oh, right. Okay, so I've asked the right question.
But go ahead, yes.
But I just wondered whether, having collected all of the data and having the longitudinal outcome,
Yes.
as well as morbidity data, you could now use the same samples, for example, the protein measurements, because cancer-seq, one of the markers, if I recollect, is actually AFP, which probably will show up in your cohort.
So, you know, there's different groups who've done all sorts of novel markers and algorithms. So just to touch first on tumor DNA, which is the kind of thing.
Which I should add, I don't think is going to
Yes.
work without proteins.
Yes.
I'll say it straight
So
ahead.
with tumor DNA, I think it will probably be like a second-line test. Whether it will be a first-line test, I'm not really sure. So, where, if you ask me, where we need a real marker is, you know, when the CA125 and lots of other starts rising, it starts rising from 5 to 10 to 15, and we can start seeing it going up. And of course, no one will operate on a 70-year-old woman with no problems with a CA125 which is less than normal, which is within the normal range. So what we really need, we had to wait for it to rise and rise till we had imaging that was positive. So we would have, like, the team would be saying it's 45, it's really rising, but there's no imaging, the MRI is not showing. So if we could get a test which could be like a second test confirming the rise, and I don't know if tumor DNA might work there to a certain extent, or another marker, AFP, HE4, which is rising at the same time. So we have some analysis and work underway. What we don't have is we have serum. So it's not plasma, so it's not ideal for tumor DNA work, because there's been, it came on, it came on room temperature on the clot. So there's been lysis of the white blood cells, so you'll need a very sensitive test to pull the tumor DNA out of that mix. But yeah, lots of exciting work. And I think people are looking at, of course, other fluids. So the vagina might give you some fluid which works better than.
Yeah.
Yeah.
We have time for just one more question from Wendy.
Yeah, wonderful study. Like Ashok, I wonder whether you had the ethics to go retrospectively back into your cohort and look at BRCA1, BRCA2.
So sorry, I should have mentioned right in the beginning, this is our low-risk trial. It does not include women who have who are a high risk. So they are part of another study we had running at the same time called UK Familial Ovarian Cancer Screening Study.
But they still might have BRCA1, BRCA2 alleles that are not familial.
Few women might have.
Yeah.
Well, technically we don't have genetic material, but we are extracting DNA from the serum. And then, yeah.
Yeah. Okay.
Wish we had time for more questions, but we'll have to stop here and thank Usha once again.